What is a mini-allo transplant?
With an autologous stem cell transplant, really there's only one type of chemotherapy that one gets, and that is like what's considered myeloablative or full dose of chemotherapy. So that's really meant to just wipe out everything, and so then you get your stem cells back. In a allotransplant, you can do the same thing. You can use high doses of chemotherapy. Typically it's 8 days of chemotherapy, and then you get your stem cells from someone else, and then you go on. What has been realized is that, if you're using the immune system, right, then sort of what's the point of the chemo? What's the point of using high doses of chemo? Because that's really dangerous for people. So about 15 years ago, people started doing things called mini transplants or reduced intensity conditioning transplants. So here, instead of using full doses of chemotherapy, we use chemotherapy that's a lot milder, and really the chemotherapy is to suppress the immune system of the patient so that the new immune system and bone marrow can go in. So it's really more like immunoablation, not bone marrow ablation. And so because of that, oftentimes patients' blood counts will not go as low. Sometimes you don't get as many of the side effects of the high-dose chemo. A lot of people don't lose their hair. There's not as much nausea, things like that. So most of the time now when we do an allogeneic transplant, it is done with a reduced intensity conditioning or a mini transplant. The other is that when I started doing transplants, we only had full myeloablative transplants, and the upper age limit to get a transplant, an allotransplant, was something like 55 or 60, because the chemo plus the transplant, getting it from someone else, was so dangerous. If you lowered the chemo and make it a mini transplant, you can do this in 75-year-olds, 80-year-olds, and so you can expand the number of patients who get allo transplants dramatically, and especially for diseases like myeloma, where most of the people are elderly. So it allows you to do allo transplants in many, many more people.
An autologous transplant, we use a high dose of chemotherapy to wipe out the person's marrow. Traditional allo transplants, where we had a myeloma in a person's bone marrow, we wanted to kill the myeloma and put in a new bone marrow, which then gives them a new immune system. Those were the goals. So we would take a high-dose chemotherapy again, destroy the person's bone marrow, and instead of giving them their own stem cells, we would give another person's stem cells and then give them medications to suppress the immune system so that they don't reject those cells. That was called a traditional myeloablative transplant. And that was a type of transplant for myeloma that was done in the olden days, and it had a lot of problems because myeloma patients are generally older, more fragile. Myeloma affects the body in many other ways compared to certain other diseases where we do this procedure like leukemia or lymphoma. Myeloma is as anybody with myeloma knows, it affects the bones, it affects the kidneys, it has multiple effects on the body. It became very toxic, and the mortality rates of patients who underwent this procedure was so high. In fact, the first clinical trial that compared this modality versus auto transplant and chemotherapy had to be closed down because the allo transplant, the traditional allo transplant, were too toxic. So then we came up with a different way of doing it called a mini-allo transplant, where the actual chemo that we give is very light, and in fact so light that sometimes you don't even need to get admitted for this transplant. You could all do it with daily visits to the hospital and going back to your home every day. So those transplants, we use what we call lymphodepletion, or similar to what we do for CAR T therapy, for example. All you need is to suppress the immune system just enough so that the donor cells are able to be tolerated by the recipient. And those are the mini-allo transplants that virtually almost all of the transplants that we do for myeloma in the allogeneic setting are mini transplants now.
What is an auto-allo transplant?
So an auto-allo transplant is basically an auto transplant where you get a standard autologous stem cell transplant, and then after that you're going to do a mini or a reduced intensity conditioning mini transplant or allogeneic transplant. So it's an auto transplant followed by mini. And you might say, well, why would you ever do that? Well, an auto transplant is really good at getting rid of myeloma, right? It's just not good at keeping myeloma away. So what we found in an allotransplantation is that the less myeloma you have before you have an allotransplant, the better the transplant will work. So one way to do that would be to try to destroy as much myeloma as possible, and one of the best ways to do that is an autologous transplant. So you do that first, you wait about a month, and then you do an allogeneic transplant. So it's a combination thing. It's sort of like if you did a full allo transplant, you get high-dose chemo, then the allo transplant. This is like you get full-dose chemo, but then you wait a little while, and then you get the allo transplant. So it's separating those two out in time, which makes it a whole lot safer than doing high-dose allo in a patient just all in one.
What is a Haplo-Allo transplant?
So haplotransplants it depends on the donor. So most allogeneic transplants that are done are using what's called an HLA matched SIB. So it's matching these two different sets of proteins, and you get half of them from your mom and you get half of them from your dad. And so if you have a sibling, one sibling, then the chance is going to be 1 in 4 that you guys totally match 100%. In the case of a haplotransplant, what you can do is you can be half matched. So you can get 1/2 from your mom or 1/2 from your dad. So in that way, for a sibling, you can have fully matched, both sets are matched. One set is matched from your mom or one set is matched from your dad. So it's actually 3 out of 4 now for a sibling. But if you think about it, if I have kids, I'm going to pass on my genetic information to all of my kids. Or my parents are going to pass their information on to me. So my kids are going to be 100% matched, half matched. And my parents are going to be 100% half matched. And so by doing that, it dramatically expands the number of donors you can do. An important thing is that for patients who are older, who get an allo transplant, one of the most important features is what is the age of the donor. Like, you want to use young, fresh, healthy bone marrow, right? And so if you're 75 and you get a disease and you need an allo transplant and you're relying on a sibling, that sibling is probably going to be like around 75, which is older. But if you have kids that are in their 40s or 30s, that is much younger. So it allows us to use younger donors for older individuals. And then you get less of what's called graft versus host disease. You probably get more cure rates. So it's good to use good, fresh marrow. You don't want to use older marrow. So doing a haplotransplant dramatically expands what you can do, the number of donors, and it allows you to use younger donors. You could even, if you think about it, you could use grandchildren as donors. You could use cousins as donors. So it really expands the number of people who can get a transplant. It's estimated that with haplotransplantation, it's probably about 95% of people will have a match. Whereas with a matched allo, a regular full allo, not a haplo, it's probably about 40 to 50% of people will have a match. So it really dramatically allows more people to get transplanted.
Haplo stands for haploidentical, and what has happened over time is that in order to do allogeneic transplant, we have to find a suitable donor. So that in the case of multiple myeloma, the earliest donors were sibling donors who were matched, or family donors who were matched immunologically. Later, unrelated donors were found, and there's been many transplants performed with unrelated donors who are matched, or occasionally mismatched at a certain location, so that genes. About 25, maybe 30% of patients have a matched sibling donor. By going to the unrelated donor, by looking for matched unrelated donors, we can expand so that somewhere between 50 to 80% of patients may have fully matched unrelated donors. However, there's still a proportion of patients that don't have a suitable donor, and then we need to consider what in the past has been called alternative donors. One type of alternative donor is haploidentical, which means that family member who is matched, so for example, a sibling who is half matched, where they inherited the same set of chromosomes, same set of genes from one parent, but not the other. That would be a haploidentical sibling. And then a parent or a child would also naturally be haploidentical. So those haploidentical donors can also be considered as transplant donors. And what's been very exciting lately is that the results of haploidentical transplant are now approximately the same as unrelated donor transplant. The other alternative donor would be cord blood transplant, and there's just been very few cord blood transplants performed for multiple myeloma compared to leukemia, for example. There's been a lot more cord blood transplants for leukemia, a lot more gemcitabine transplants by the pediatric population. But in multiple myeloma, we probably consider the next step after a matched unrelated donor might be to consider haploidality transplant.